Amebiasis. It is an intestinal bowel illness caused by a microscopic protozoal parasite called Entamoeba histolytica, which spreads through the oral fecal route. Often it is asymptomatic, but sometimes it causes diarrhea, amebic dysentery, nausea, and weight loss.
Etiology of Amebiasis. Entamoeba histolytica exists in two forms, cyst and trophozoite. Cysts are present only in the lumen of the colon and in formed feces and range in size from 10 to 20 micrometer.
The cyst may contain a glycogen, vacuole, and chromatoid bodies. Masses of ribonucleoprine nuclear division occurs within cyst, resulting in a quadrinucleated cyst, and the chromatoid bodies and glycogen vacuoles disappear. Trophozoites usually appear only in adiuretic feces in active cases and survive for only a few hours. The cytoplasm has two zones, a hyaline, outer margin, and a granular inner region that may contain red blood cells. The nuclear membrane is lined by fine, regular granules of chromatin, with a small central body endosome or karyosome.
Pathogenesis of Amebiasis. Infection starts when an individual ingests cyst orally from fecally contaminated food and water. Disease results when the trophozoites invade the intestinal epithelium and form discrete ulcers with a pinhead-sized center and raised edges, from which mucus, necrotic cells, and amebe pass. The trophozoites multiply and accumulate above the muscularis mucosae, often spreading laterally.
Rapid lateral spread of the multiplying amebi follows, undermining the mucosa and producing the characteristic flask-shaped ulcer. Of primary amebiasis, subsequent spread may coalesce colonies of amebi, undermining large areas of the mucosal surface. Trophozoites may penetrate the muscle layers and serosa, causes perforation into the peritoneal cavity. Resulted enlargement of the necrotic area produces shaggy overhang edges, secondary bacterial invasion, and accumulation of neutrophils. The organisms may travel to the terminal ileum, producing a chronic infection. The sigmoid colon and rectum are favored sites for later lesions. An amebic inflammatory or granulomatous tumor-like mass. Ameboma may form on the intestinal wall, sometimes block the lumen. Factors that determine amebi invasion include the number of amebi ingested, the virulence, gut motility and immunity status, and the presence of amebi. Growth-promoting enteric bacteria. Symptomatology and clinical manifestation. Symptoms include abdominal tenderness, dysentery, and dehydration. In less acute infection, symptoms appear gradually and often includes diarrhea, abdominal cramps, nausea and vomiting, and an urgent desire to defecate, general discomfort, loss of appetite, and weight loss, and malaise. Symptoms may develop within 4 days of exposure, may occur after a year, or may not occur. Extraintestinal metastatic infection rarely occurs by direct extension from the bowel. The most common form is amebic hepatitis or liver abscess, which is due to trophozoites carried through the portal circulation. Rarely, amebic abscesses may occur in lung, brain, and spleen.
Laboratory diagnosis: the wet preparation of stool. Specimen is preferred, the presence of trophozoite showing. Ingested RBCs are pathognomonic. Serological diagnosis may also be carried out to detect antigen and/or antibodies in the serum of the patient. Treatment of amebiasis: metronidazole flagyl is the drug of choice for the treatment of amebic dysentery.